There we go. All right, it's 11 o'clock and we're going to go ahead and get started. Good morning and welcome to the April EP&R Lunch and Learn on PHEP Capability 15, Volunteer Management. Today's presenter is Mike Magner, who is currently the state coordinator for the Virginia Medical Reserve Corps program and has been since March of 2022. Mike's been with the VDH Emergency Preparedness Program since 2004, serving in various roles at the local, regional, and state levels. Mike is also an Army Reserve Colonel in the Medical Service Corps with over 29 years of service. Over to you, Mike.
All right, thank you, Donald. Go ahead and get started here. All right, so here's my agenda today. I'm going to be covering Capability 15, which is volunteer management. Talk about how we coordinate volunteers, notify volunteers, organize, assemble, and dispatch volunteers. We'll talk a little bit about volunteer safety, health monitoring, and surveillance. A little discussion on demobilizing volunteers, and then managing spontaneous volunteers. All right, so coordinating volunteers, that's kind of it sounds like a simple concept, but it actually starts with recruiting, identifying, and training volunteers. And this is, again, right out of the PHEP 15 capabilities list and the description there. But the first step is the needs assessment. So we need to identify how many volunteers are needed and what type of volunteers are needed. So we typically divide Medical Reserve Corps volunteers into medical and non-medical. And then medical volunteers are subdivided into doctors, nurses, advanced practice registered nurses, LPNs, etc. But in determining what volunteers you need, you have to look at your current response plans. You have to look at a staffing assessment and identify a gap analysis. So, for example, you're going to have a point of dispensing plan that says we need X number of screeners and we need X numbers of vaccinators or pill dispensers. And you're going to look at, okay, we already have this many staff members on hand that can do those jobs, but this is how many open slots that we still need to fill. And that's really your gap analysis. And you can do this for your sheltering plans. You can do this really for any emergency response plan where large numbers of people are needed, and the people that you have on hand that work for you full time aren't necessarily available to fill all those roles. So that's your volunteer gap. And then you look at how many volunteers do we already have on hand. So we have Medical Reserve Corps programs that cover every district in Virginia. So you already have volunteers on hand. So your remaining gaps would be your volunteer recruitment need. And just because you have a volunteer on hand doesn't mean they're going to be available in every single emergency or situation where you're going to need them. And, there's a limited number of shifts they'll be able to serve in a given time period. So you'll need to, identify what that gap is and then go out and recruit those volunteers. And that recruitment should be targeted to contact and recruit the volunteers that match those staffing gaps you've identified. And then once you identify volunteers and they say, yes, I'm willing to sign up, then there's an enrollment process, which includes the volunteer filling out an application, a volunteer coordinator reviewing that application and approving it if appropriate. And then that approval process also includes a background investigation. If they claim they're a medical provider, we need to look to see if their credentials are current and valid. And then we can assign that volunteer to the unit, and we can further assign that volunteer to a specific group or role that supports specific emergency response plans. And then we need to train our volunteers. So, training starts with a training needs assessment, or TNA, to determine what training is needed to support our existing emergency response plans. And then once we've identified that gap, we develop training to fill that gap. And then we have to deliver the training and document completion of the training. All right, so that's how we coordinate volunteers or manage volunteers prior to the emergency. And now we're going to move on to how we notify volunteers so that they can come and work during a response. So in Virginia, the Virginia Volunteer Health System, or VVHS, is our Virginia's emergency system for the advanced registration of volunteer health professionals, or ESAR VIP. When you look at the PHEP capabilities that are provided by CDC, you won't see VVHS, but you will see ESAR VIP listed throughout that document. And for us, that is VVHS. So again, we use VVHS as a one-stop shop for volunteer applications, volunteer management, volunteer notification, mobilization, and deployment. That system is used to send out alerts specifically to notified volunteers. And we could alert by MRC unit, we can alert by region, or even do statewide alerts, which we've done most recently for Hurricane Helene, but it can be done, pretty much any time. And when we send out alerts, we can alert volunteers by groups and roles. We can also alert by specific training that they may have. So if we want just vaccinators, we can alert only those people who are qualified to vaccinate and have completed all of the vaccine training required to vaccinate. And then we can also send out alerts by medical level. So suppose we only want, doctors, we only want nurses, we can alert by that as well. And then when we send the alert out, the volunteers indicate, hey, I'm available for this shift or that shift, or I'm not available at all. And then so we get that list back from VVHS of who's available for which shifts. And then usually it's the MRC unit coordinator that will place those available volunteers into their mission assignments. Although it doesn't have to be the MRC coordinator, it could be the local health emergency coordinator or somebody else who's designated to map those volunteers with specific shifts and assignments that are needed for that emergency response. So the next step is to organize, assemble, and dispatch your volunteers. So once you've identified, hey, we've got 6 volunteers that are available to fill these next 12 shifts, because they can come back tomorrow and fill additional shifts. We've got to organize them and assemble them. So like as I mentioned, we've organized them already in the shifts and roles. But then we got to think about how they're going to assemble. Are they going to go straight to the incident site where they're going to deploy to, or are they going to go to a staging area or an assembly location? How are they going to check in? Who's going to check them in? Are they going to require just-in-time training? They should get a safety briefing every time they're deployed. They should get additional assignment instructions. So they may have had training on pods, but now they need specific training on their specific role and how it's going to work at that location on that day. And then what's their communications plan? So if we're going to have volunteers that are dispersed, say at first aid tents around a 10K race, how are they going to communicate? Are they going to be given walkie-talkies? Are they going to be given a phone list? Who do they contact in an emergency? All of that needs to be provided to them when they check in. And then is there any PPE that's needed? So for instance, when we did testing events during COVID, there was a very specific PPE requirement of masks, face shields, gloves, etc. And that was issued to the volunteers. And then, we have to move them from the assembly area, if that's where they're meeting, to their area of assignment. So that could be as simple as moving from one end of the gymnasium to the other. But it could also be somebody driving them out to a first aid tent somewhere where they will be assigned. And then we need a plan to pick them back up. So if we're driving them from an assembly area, out to a first aid tent that's 6 miles away, somebody needs to go and pick them up and drive them back at the end of their shift. So got to remember that piece of it as well. All right, so let's talk a little bit about volunteer safety, health monitoring, and surveillance. First part of safety is, identify and mitigate any specific hazards. So you want to look at, what are some environmental hazards? Are we working indoors or outdoors? If outdoors, what is the weather like? Is it hot? Is it cold? Is it rainy? And how do we protect our volunteers from those hazards? What are some hazards related to their work? Are they going to be handling needles? Is there a potential for needle stick injuries? How do we mitigate that? What do we do in terms of training, equipment, and supplies that can reduce that hazard? In some cases, we might need to do health screening. So, for example, if they're going to work in a TB testing clinic, a tuberculosis testing clinic, if you will, sometimes we need to screen them ahead of time with the TB test to see if they've had prior exposures to TB. In other cases, the work may be physically demanding, and we might require that they have a note from their doctor that says they can do physically demanding work. So those are just different scenarios. They wouldn't apply 100% of the time, but it's just something to think about. And then when you set up your work site, you got to think about fire safety plans. You got to think about mitigating the hazards of trips, slips, and falls. We like to set up a lot of computers and a lot of power cords. Those are easily things that we could trip over if we don't mitigate that through, different things like covering up cords, using those little ramp things that you can put over them so that they're very visible and people can walk over them without pulling the cord from the wall or tripping over them. And then, training and PPE also mitigate hazards so people know how to perform their work safely, how to use proper lifting techniques, and proper needle disposal techniques. That can go a long way to preventing injury. And of course, PPE that's appropriate to the job that's being performed and not expired or damaged in any way. And then prophylaxis, if applicable. So if there is a specific vaccine that's available to prevent an illness, like during COVID, vaccine events, we required for a little while for our volunteers to be vaccinated against COVID before they could volunteer for that event. Some of the clinic assignments in the health department clinics require things like a seasonal flu shot or proof of a hepatitis, A shot. So those are all things that need to be taken into consideration. The surveillance piece is really about having documentation ahead of time so that, volunteers can sign up for these assignments, and we've tracked that they've completed whatever health screenings or prophylaxis is needed. If accidents or injuries do occur, first thing we'll do is apply immediate first aid. If needed, we'll evacuate them to a higher level of care. In other words, call 911. Obviously, not every injury requires a trip to the ER, so that would be at the discretion and based on the incident itself. And you want to document the injury. So we currently use a client occurrence reporting form. It used to be a paper form. Now it's a red cap survey available through the VDH web. And when volunteers seek outside care, they first use their own health insurance to pay for any medical care received. After that, they may have cost shares or deductibles. We can't pay them directly, but VDH is covered by the Commonwealth of Virginia Risk Management Plan, which places a limit of $100,000 for tort claims. And basically, the injured volunteer would have to make a claim against this plan. So they kind of have to sue us in order to get reimbursed for the cost of care for their injury. That's really the only provision we have in place for volunteers. And a lot of people ask about workers' compensation. Say a volunteer is on a work site and they get injured to the point where they can no longer work. That's unfortunate. And this is something that we let volunteers know during their initial orientation before we ever deploy them, that we do not cover workers' compensation because volunteers work for free. We can't provide them, basically a payment for being unable to work for us. Now, how does that affect them if they can't go back to their normal day-to-day job and can't can no longer work? That's an unfortunate thing, and we still can't cover workers' compensation for them. But just look at the bullet right above that, and that's the tort claims process, and that's really the only compensation that they could get. So we do get a lot of questions on that, but we do try to make very clear to volunteers, that there is a little bit of risk to volunteering with the health department. And if they get injured, we are unable to pay workers' compensation. And so, we ask the volunteers to assume a certain amount of risk. And they're always welcome to say, hey, I'm not comfortable with a specific assignment. And so there's no requirement that once they volunteer that they do hazardous work. So, and when we look at the assignments we might give them, we have to take that into consideration as well. And then, something that's come to the forefront really recently are the mental and behavioral health considerations. We've gotten smarter and more aware of this, and we know that MRC volunteers may experience what we call emotional dysregulation, or otherwise known as behavioral health concerns or issues, while participating in emergency and disaster response efforts. And this could be due to any one of these factors or multiple factors. So we ask volunteers to work in austere conditions. And so that causes stress, right? So people aren't getting the normal sleep and food that they normally are used to. They're not getting enough coffee. That can cause stress. They may also have direct experience with traumatic events, or experience their own loss or grief as a result of those events, and or may receive vicarious trauma through interacting with survivors. What we mean by vicarious trauma is that survivor tells their Halloween tale of how they barely escaped death and how they saw their loved ones not make it through. That information can weigh on the volunteer. They may have nightmares about that. What if this happened to me? What if this happened to one of my children? And then there's also the potential for moral injury if they're not able to save anyone, if they are working in a chaotic scene and some of the people they try to help ultimately don't make it or don't get better, or don't seem to respond well to the services they're providing, then that could cause additional stress as well. Here's some prevention techniques that we can take to try and reduce the risk that volunteers will experience these sort of behavioral health and mental health concerns. One thing we can do is before, during, and after deployments, just communicate really well with volunteers. The biggest stress that volunteers will probably have is just not knowing what they're walking into, or not knowing what they're supposed to do when they get there. So the more we can communicate with them and train them and make sure that they're ready for that assignment, the less likely they are to have these kinds of responses to the event. Also, teamwork and pairing volunteers with experienced responders. So if you have a new volunteer that hasn't worked in that scenario before, teaming them up with somebody who's, been there, has the experience, has the training to do that, will go a long way. Meeting our volunteers' immediate physical needs, such as food, warmth, shelter, security, and providing adequate work rest cycles will also help. And then acknowledging the physical limitations based on their current or previous life circumstances or experiences. I know there's sort of a tendency to believe that all of our volunteers are senior citizens. That's really not true. It's only about 30 to 35% of our volunteers are actually over the age of 60. But they do make up the largest demographic of our volunteers. So we have a smattering of volunteers everywhere from 18 to 59, with a huge chunk of volunteers over 60. But then again, like I said, it's only about 30 to 35%. And then encouraging the volunteers to practice good mental wellness habits, which include diet, exercise, and social engagement before and after these response events. Post-deployment, it's a good idea to reach out to volunteers that have worked in a high-stress situation and conduct post-deployment surveys. We're looking to make that easier in VVHS. One of our future upgrades will allow us to send them an automated link to a pre-can post-deployment survey. And that allows them to provide any input to any aspect of the deployment, from the alert all the way through post-deployment, and give them an opportunity to say, yes, I want to be contacted by my unit coordinator or somebody for additional services afterwards. Another thing we can do is what we call debriefing sessions. So post-deployment, if we know based on our post-deployment surveys that we have one or more volunteers that could benefit from debriefing sessions, we can pull those together and work with our local community service boards to facilitate those. And we can, encourage our volunteers to engage in help-seeking behaviors. Most people, if they have health insurance, it does cover behavioral health care and services that, a lot of people don't realize they have those benefits. So it's really just about reminding them that those benefits are probably already there in their existing plans. If we have somebody that doesn't have health insurance and they really need assistance, we have worked through the state leadership to make arrangements for them through the employee healthcare plans. That's kind of a rare circumstance, but that's something, we can always ask about. So never give up on trying to help your volunteers is the lesson there. And just to support mental health and behavioral health considerations, we have just recently in March updated our Virginia Department of Health Emergency Response Plan, Annex 1, or Annex I, sorry, Volunteer Management Plan, and added an Appendix F, which lists out all of these things in great detail that I've just covered. All right, so we'll talk a little bit about demobilizing volunteers. It's important to have a checkout process that is communicated to everybody ahead of time. So when they check in, they should know what the checkout process is. It shouldn't be a surprise when their shift ends. And that process should account for all staff and volunteers to make sure nobody was left behind or left out at some first aid station far away somewhere that people have forgotten. We got to get all of their equipment and supplies turned back in. Ideally, we debrief them and do a hot wash, so we would get their input into how the plan went prior to them leaving while the information's still fresh. And we got to think about our transportation plan. So if we had to transport people out to a site, then obviously we have to transport them back. So what about managing spontaneous volunteers? So I'd say we have a major disaster and, have widespread destruction, our normal support systems aren't in place, and people want to come in from other places and do everything they can to help. And that's great. Sometimes that can be a lifesaver. Sometimes that can create more of a hassle for us, frankly. But these are the steps that we need to go through. So the first thing is to determine whether we have a need for spontaneous volunteers. If not, then don't accept them. So, the need would be that you have more open slots for volunteers than you have on hand. and maybe you're unable to use VVHS due to power communications outages, or maybe there's other extenuating factors that say, yes, we really do need external volunteers that are not already registered in VVHS to come help us manage this disaster. Now, keep in mind that we not only have our local unit volunteers, but we do have the capability to mobilize additional volunteers from the region or even statewide. So, for example, during Hurricane Helene, we mobilized volunteers from other regions even to travel across the state and participate in shelter and vaccination events in the town of Galax in Mount Rogers district. So, a lot of bad things have to happen before we get to the case where we really need these spontaneous volunteers, but I can't rule it out. So definitely want to have this as part of your plan. And so that plan should include, either a physical or virtual recruitment location. Virtually, right now, people can log into VVHS anywhere they can get internet access. It's a web-based application. They don't need any special software. They just need to know the correct URL to go to VVHS and submit an application. Normally, that application can take days or weeks to process, but in an emergency, we can speed it up by deploying resources from the state team. And so we have to onboard them. If we don't have VVHS available at all and we're doing a paper sign up, then you just need to develop a process for taking paper applications or paper signups. And then how you're going to verify their license if they're going to work as a medical provider. And then are we going to stage them in a different area after they sign up to get their assignments, or are they going to get assigned straight from the sign up location? And then we're going to have just-in-time training. So if these are spontaneous volunteers, they don't know us, they don't know our response plans. So we're going to have a way to provide training for them. As part of the deployment, those instructions on what specifically they're going to do, how we're going to identify them. So are they going to have badges? Are they going to have vests? Are they going to have a uniform? And then we deploy them out, and then we need a redeployment plan for our spontaneous volunteers, just like our regular volunteers. And then, the same sort of post-deployment monitoring that we talked about for our regular volunteers. And there's more information on managing spontaneous volunteers in our VDH Emergency Response Plan, Annex I, Section 6D. And then, if we got volunteers from out of state, during certain declared emergencies, we can use out-of-state medical volunteers if they have valid, unexpired license, and you can verify their licenses. PowerBridge is a third-party site that does offer a voluntary nationwide medical credentialing services, and that it's voluntary in that providers actually have to sign up in ProviderBridge in order for their license to be available in that system. And we do have a button in VVHS to do out-of-state license check, and it really only looks on ProviderBridge for those out-of-state credentials. And there's a little picture of what it looks like. And then this is just our map of our units and what districts they cover, and the names of our unit coordinators. And that's pretty much it, pending any questions.
All right, if there are no questions or comments for Mike, I'd like to thank him for presenting on PHEP Capability 15, Volunteer Management. Again, thanks for taking time out of your busy schedule, Mike. And this will conclude the April EP&R Lunch and Learn. Thank you, everyone, for your participation.
Thank you, Donald.